Welcome everybody in the galley, and welcome to our esteemed panelists on this incredible topic, incredibly important topic in today's ecosystem and everything, considering everything that's going on in oncology and applying the virtualization of care and really within this pandemic environment, how are people managing the virtualization of care? How are they managing patient populations in general? Primary care has been heavily affected, obviously. It's been cut across all 26 major diagnostic areas. And in today's topic, we're going to be talking specifically around oncology and about how the pandemic and how the virtualization of care has affected oncology and what some of the leading thought leaders and what some of the leading clinicians and innovators in oncology today in today's world from from not only the Mayo, but also Brigham and Women's and Mass General and Persistent, what they are doing around being able to solve for this puzzle. And again, I want to thank Persistent and all the good people there for their sponsorship of this program and their contribution to the digital health community, not just in the US, but globally, in responding to the pandemic and providing extraordinarily deep resources to people in need that need to understand how to very rapidly shift their infrastructure in IT and digital health in this pandemic. And so with that, I wanted to go into some introductions and just begin to introduce the panel to our audience. And first and foremost, myself, my name is Stan Kuchanowski, I'm the moderator. I am the director of the Digital Health Program at Columbia Business School. I'm chair of HIT Lab, Digital Health Testing and Efficacy Testing Lab in New York City. And with me is Dr. Rafael Fonseca from the Mayo Clinic. And Dr. Fonseca, if you could give us a couple minutes background on yourself, please.
Sure. Well, thank you very much. And thank you for the invitation. I'm very much looking forward to our conversation. So as you see there, I'm currently the interim executive director for the Mayo Clinic Cancer Center. I'm a hematologist and oncologist, and I've been with Mayo Clinic for over 20 years. I specialize in the area of multiple myeloma, so that's all I do in my clinical practice and my research, in addition to my administrative duties. In addition to serving in this capacity as the director for the Mayo Clinic Cancer Center, this is enterprise-wide for the Cancer Center. I'm also director for innovation and transformational relationships here in Arizona, which really tries as a position that tries to address issues, related to connectivity, digital solutions, platform, and the like. I would like to self-describe myself as a techie, and despite the headset you see, which may not seem very modern, this work environment lends itself better when you have a headset. But I'm just delighted to see what we're able to do now with remote connection and telemedicine. And I know we're going to talk about this, but I'll just start with a statement saying that I think the genie is out of the bottle, and I can't wait to see what the future looks like as we go through the next wave of offerings.
I love it. Yeah, I think that's certainly going to be one of the big topics of conversation today, and want to certainly dive into that. Next on the panel is Sarah Salacci. She's the Chief Strategy Officer at Mass General. And Sarah, a little bit of background on yourself, please.
Sure. Thanks, Dan. And thank you, Persistent, for sponsoring. And thank you both for giving me an excuse to put on my big girl clothes. It was a treat. So yes, I'm Sarah Salacci. I'm the founder of Mass General Center for Innovation, Digital Healthcare. I'm also the Senior Managing Director and our Chief Strategy Officer for Digital Health and Innovation and Connected Systems. I've been in healthcare a little over 20 years. Started my career working in Medicare rights advocacy in New York City, worked for Memorial Sloan Kettering Cancer Center, Boston Children's Hospital, and came to Mass General about 13 years ago to work with the Mass General Cancer Center. So I've spent a large part of my career working in cancer. About 3 years ago, in discussing with leadership where Mass General potentially had some more opportunities to innovate and better organize and coordinate our efforts, decided to move into digital health. I have no background in digital health. I'm not an engineer. I do not know how to code software. I'm pretty much a tech vortex at the end of the day, but in some ways I think it's worked to my advantage because able to really hone in on whether or not the technology solves a problem as opposed to how the technology works. It's a busy time still at Mass General. We just went into back into an emergency state of affairs yesterday, anticipating another COVID surge. I think though what's been really exciting, similar to what Dr. Fonseca shared, is that we've really been able to see COVID become a catalyst for how we have been able to move so much of our care into the virtual space. And we'll say just with respect to the Mass General Cancer Center, though many of the ambulatory practices had to shut down, as we know with cancer, it's just different. And so we were able to really shift our operational focuses very quickly in the cancer center to become more virtual, and happy to share more about that as part of this panel.
That's fantastic. Thank you, Sarah, for the introduction. And it's good to see a non-digital health person. It's good to see some non-engineer on there as well. And then, of course, we have Vanud Parale, Associate VP of Healthcare and Life Sciences from, again, one of the world's leading solutions providers, Persistent. Vanud, 2 minutes on your background.
Sure, Stan, and thanks for inviting me and arranging this session. Very happy to participate in this one. So in terms of what we are doing at Persistent is basically we are helping providers, researchers, pharma companies and entire healthcare ecosystem basically to apply digital health using technology as a frontier to solve, certain problems and, right from research up to providing care. And I'm very, very kind of fortunate to have been involved in some of the very sizable programs with very, very interesting outcome from that perspective. And I've been in this area for almost 8 to 10 years now, applying technology for healthcare related problems, and maybe clinical issues, it may be operational issues. And we have seen very interesting trajectory since COVID has started. And I've been part of the team that is advising on technology side for to these healthcare providers and researchers on how technology can be useful, to kind of care for their patients, and especially from oncology faculty perspective, we have been very engaged on two folds, right? And as discussion progresses, I'll talk more about specific examples how we have been helping a research community as well as care community to use digital health and technology to care for their patients. Thank you again, Stan, and looking forward to conversation.
Yeah, likewise. And I think we're honored to have you here as well, and just all of the hard work that you've put in, your teams have put in to helping rapidly virtualize a lot of these healthcare systems over the last 10 months. And I think we're going into a wave now where we're going to need more of that. And then finally, I'd like to introduce everyone to Richard Boyden. He's out of Brigham and Women's Hospital in Boston. They don't have snow yet, but they're getting there.
It's cold.
It's cold. Yeah. So Richard, if you could please give us 2 minutes of background on yourself as well.
Yeah. So I'm a nurse practitioner by training, and the creator and the director of the virtual prostate cancer clinic in the Department of Radiation Oncology here at the Brigham and Dana-Farber. And basically, we've been operating since 2016, where with a digital health platform that I'll say I'm just enough techie to be dangerous, because I was able to program my own proof of purpose, if you will, of how we can manage people from a distance versus having them come in and saving them the time. And it's kind of been an ambition of mine since I was actually an oncology patient. I was diagnosed with leukemia back in 1996 and ended up having an allogeneic stem cell transplant, and coming into the hospital a lot, as Dr. Fonseca could tell you that. So coming in there a lot, and then after a while, it was, how could I come in less to try and get back to my normal life and not be, still get the care I needed, but maybe from a distance, so I don't have to travel so far and spend so much of my life, in a clinic. And that's always been a drive of mine. And thankfully, and working in the radiation oncology department with prostate cancer patients, I thought there's got to be a better way to do this. And that's what led to us building that initial test platform to manage people from a distance where they didn't have to come in anymore, and they could get their care, and we could make sure they haven't relapsed and deal with any symptoms that they have in a more remote manner. And I'll say that it helped our department a great deal when the pandemic really hit in March, and we had already had this up and running for a number of years. The GU radiation oncologist, it was a smooth transfer of care to our clinic, and didn't have to work on the fly like so many other people did.
Yeah, I think that's stunningly important, and the transition that we've seen now is incredible. Let's jump into this. I think the ideas around where we're focusing have a number of different issues and a number of different facets to this never-ending type of puzzle that we're working with here. What I'd like to do is first jump into this this question around economies. Hospitals right now are struggling more than ever with reimbursement, and I'll make this first question a jump ball. Whoever wants to jump in first. But what are some of the economics around the virtualization of cancer care, as cancer patients are trying desperately to maintain their regimens, as they're trying desperately to get their labs done, get their tests done, and maintain their therapies. What are some of the economics around this, not only in terms of the patient costs, but also the hospital costs and the revenues?
So maybe I can take a first stab at this, Stan. Happy to answer. This is probably one of the most interesting aspects of what we're seeing with virtual care. When it comes down to sustainability, a lot of what really keeps the lights on is the administration of medications and the procedures in hospitals, and the actual, as many of in the audience know, the charge for the visit is just a small part of what we do. But unfortunately, that's the way that people have protected time, and that's the way in which doctors can spend some time explaining and planning with patients and going through those so important conversations. Well, it turns out that historically you can only do that when you're in that face-to-face, but the value of that is very limited, because if you live next door, maybe that's okay. But if you're 4 hours away and someone has to drive you and someone has to take a day off of work, and maybe you have to pay for lodging, gas, and meals, no matter what happens with the insurance, it's right there. There's a significant negative for a patient and their family members. And the way this works out, in my opinion, and I think we're just starting to see the first sort of wave of information come back from that, is that hospitals can actually be successful if they apply the ability to see patients now in these tools, and don't think about it as a unit, but actually as part of the whole, where maybe oncologists can see more patients, maybe those patients can still come and receive the care, and the hospitals can recognize the revenue. And it's also of great value for patients, because then they don't have to lose all of that I alluded to. So again, this plays out in different ways for the different cancers, for the different types of therapy we give. So there's a lot to unpack in that answer. But I would propose that at first glance, there are great opportunities for better value as we do this.
I'd be happy to. So, I focused, I developed a digital health platform really to try and change the traditional oncology model of care, which was you have an in-person consult, then you're treated, and then you enter this long follow-up phase, at least in prostate cancer. And so basically, it was actually quite simple in regards to thinking about, okay, how do we, as Dr. Fonseca said, how do we free up the doctor to see more patients, so increase access to care? And, with the digital health platform, what we were doing is we were offloading the in-person follow-up visits, so that we, could free up the doctors to see more consults. And that was kind of the theory. And hopefully we'll have a paper out soon, but we're able to reduce, from when we started 2000 and FY19 now, it's 24% reduction in in-person follow-ups. And we had an increase in actual consults of over 100%, because we freed the docs up so much that they were able to bring in the consults. And the other thing was that in radiation led to more people treated. And that, and it also for oncology in general, it depends on the model of reimbursement to how economically feasible things are. But doing that in radiation oncology, people will know. I mean, we were able to increase revenue compared to before we started by 74% in FY19. And in radiation oncology, that's not small chump change. And so, but ultimately it's looking for me, and that's kind of where you have to look at the economics of it, is maybe not being wed to the traditional model and giving up revenue on one side to gain it on the other side. And it's looking at where the revenue comes from. And, ultimately increasing access to care is always going to be a better thing. And that, and that's kind of what our focus was on, is reducing the need for them to come in for visits for follow-ups, so we could increase access care on the front end. And being able to treat 20% more patients is a big deal. So
now, where does that 74% increase? And that's a stunning number.
I cannot disclose. My chief financial officer is percentages are what I have to report. But
no, just curious, is it because other people were not able to do scans, or was it where did that? Because most people are
prostate
seeing
cancer is one of the largest group, obviously, for men, and there's an abundance of people looking for, especially from academic centers, such as Dana-Farber, Brigham, as well as Mass General, the Mayo Clinic, Sloan Kettering, so there's a lot of people coming that want to come in. And so it reduced the backlog. And in a lot of, I'll say in prostate cancer, at least, if you can get them in sooner, they'll tend to stay with you. So if you're, and that's just, what we've seen, that, so that's how we've been able to increase, is literally just by freeing time for these doctors to see the consults. And, and again, traditionally we used to think of that as a 1-to-1 ratio, whereas we're called now we're advanced practice providers. So we'd offload to a traditional in-person clinic to the APPs. But, again, you're still limited by space and time. And so what the digital health platform allowed us to do is to really manage a larger volume of patients with less people, and I just to say, we also have excellent post-visit data that the patients like this care a lot, because they know that we're still a point of access. And if they do relapse or they run into a problem, we can still bring them right back in, and they get, the doctor who they trust so much.
It's fantastic.
Yeah. I think another important point to drive home from what Rich just shared was the cost savings piece, right? So there are going to be activities that we can embark on that will help increase our revenue, leveraging new billing codes for remote patient monitoring, et cetera. But I think there's also an opportunity for significant cost savings. There's a study that came out at ASCO, virtual ASCO this past June, said the cost of cancer would increase by, I think it was close to like $250 million, $250 billion between now and 2030. Now, granted, that's data pre-pandemic, but that was largely based on pre-pandemic. But that's a significant number, obviously. And so, if you look at where there could also be opportunities to cut costs using virtual tools and digital tools to, say, reduce readmissions, to reduce length of stay even. So we're able to, and we saw this through the COVID surge, wanting to discharge patients as soon as we could and be able to send them home with tools that would allow us to monitor them and connect with them in what at the time their home environment, so that we could free up capacity for our inpatient environment. But it's also, I think, an opportunity to start to provide a different level of care and connectivity between the provider and the patient, which has, again, more of a qualitative value, but could have downstream effects on the on our revenue streams and cash flow. So, for example, anything in supportive care, right? Interventions that allow a cancer patient to connect with the provider to prevent a readmission. So I think there's another study that came out, maybe it was before COVID, there's just like everything before COVID is one big time frame, but it was within recent years that said 45% of cancer patients are readmitted because of anxiety as opposed to actual medical need, right? And so this was a tenet that really rang true for us at Mass General, and we worked to employ and deploy some digital tools that monitored patients post-acute discharge, and started to see great success with that. We're looking to get that pilot back online as soon as we return to normal operations for some sort of consistent period of time. But the biggest feedback we got from patients who participated thus far was, I felt so much better being able to connect with my provider at a moment's notice, or even for a video visit, I could just see somebody's face and know that somebody was paying attention. So I think it will have great effect in the supportive care space.
Yeah, I mean, that's incredible. Just looking at the the numbers that Richard's talking about, I think if this becomes something that is built in to the infrastructure, and it can be and it's economically viable. Becker's Healthcare just reported today 32 more hospitals declare bankruptcy. Stunning. I mean, just in the last couple of weeks, it says, and then we're seeing it every week. I mean, the magazine now, or whatever you call these things that are online magazines, publications, are now just, it's a report. It's the bankruptcy report every week. So Vinood, I know you've got a lot to say in this topic. You guys are out there in the trenches helping enable this extraordinary panel and what they're doing. What are you seeing around the economics of this new virtual care model in cancer?
I just wanted to extend on Sarah's point that it is like just sheer feeling in patient that I can connect with my provider as and when I want. That itself is like, awesome like tool for patient to have, right? And then second part I wanted to mention, we come from technology background, but if you look at the patient engagement and patient, experience, especially for long-term care faculties like, oncology, it is at most very, very important point that, patient feels connected. And, we are working with multiple AMCs and providers and health systems. And one of the health system, executive was explaining, cancer center executive was talking to us, and he was explaining it is so frustrating for some of our patients to, call in just to check, when is their pre-surgery checkup, right? For example. So it is like so many touch points that these oncology patients have with health systems and their doc. It is overwhelming, for oncology patient, right? And having digital health kind of a channel for health system, and also for a patient to connect back with health system and their care team is phenomenal, right? And I think a byproduct of that whole connectivity and engagement is what Sarah and everybody was talking about, more on economy side, more on anxiety side, and more on better result side, right? So I think all in all, I see like oncology from my perspective, digital health started with very simple things like booking an appointment. Now it is reaching up to specialty service lines and streams like oncology, and it's great to see how shift is happening, and how COVID has accelerated the shift, and this economic benefit from provider perspective, I hope will remain in longer run, and that way it gets some necessary help that health systems are looking for.
It's fantastic. And just to remind the audience out there, we've got obviously dozens and dozens of people online watching this right now. If you want to ask a question, we've got a few different mechanisms. You can hit us up on the chat box or the Q&A section of your Zoom platform, or and if for whatever reason we can't get to your question during this session, please look us up on LinkedIn. Everybody on the panel is on LinkedIn, and we'd love to be able to follow up on other conversations afterwards as well. But the really, we've gone from the economics of this. Clearly, it's not going away. Virtual cancer care is going to be here for at least another year. We don't know if it could go beyond that. And as opened up by Dr. Fonseca to start with, it's here to stay. Like we're getting to the point now where the animal spirits, a lot of that Keynesian kind of philosophical componentry is starting to really train and behaviorally modify us as a society toward virtual care. Dr. Fonseca, tell us a little bit more about what the Mayo did to scale this up, and how design, and what were some of the commonalities that you've seen from the on-site to the virtual, and what were some of the differences as you scaled up virtually to the virtual model versus the kind of physical model?
Sure. Well, I don't want to minimize the very hard work that occurred behind the scenes with our colleagues in IT, but it almost seemed like things happened overnight. We went from a few people knowing Zoom to Zoom being a dinner table conversation that just happened in a matter of a few days to a few weeks. And for us, how that was implemented, it just took some time before the connectivity was made between the electronic medical record, the fact that now in our appointment list, we have a little icon that tells you whether you're doing a video or a phone consultation that you click on. And then magically, this window opens up that technologically we knew was possible for a couple of decades, but now it's really at the disposal of patients and physicians and the care teams. So very quickly we implemented that. There were perhaps the thrust and the sense of urgency that we all had shed some of the normal hesitancy we as humans have when we try to embrace new technologies or new pathways. It just had to be done, but it turns out we did the jump, and then once we were there, we knew it was working. And if this project had been planned absent a pandemic episode like this, it probably would have taken 5 years for any health center going through 10,000 committees and legal considerations and the like. But it really transformed itself into an opportunity, whereas now we have this available for our patients. Some aspects that are fascinating are how the network of connectivity is greatly expanded. It's just very obvious. Before, to come to a medical center, you need to be healthy enough and you need to have enough means to be able to travel and have that disposable time and that disposable income to come to a center like ours or Mass General or the Brighams, because there is a cost to that, right? Number one. Number two is this actually can connect more and more the hyper specialty part of the oncology practice, which is clearly a direction that we're moving. You're seeing now people that are going to be experts on some genetic mutation in lung cancer or the right-sided colon cancer and the like. So our ability to create that more specific connection across the country and beyond, which is my third point, this has also opened opportunities for patients, around the globe. So now it's not unusual for us to do consultation for individuals who live beyond the borders of the United States. I think the sum of all of this is of great value, and it should be said too as well that we understand these are options that are not available to everyone, but fortunately more and more people have access to this. So I think the ability of cancer centers like ours and those represented in this call can also reach populations that traditionally would be left out from the more sophisticated aspects of care. So it turns out that this sophisticated technology, let's call it that for now, is actually allowing for a more democratic approach, if you may, to how healthcare is being delivered, which I think is fascinating and not talked enough, because the reality is we can reach more in less time, and I would argue better. Now, there are some aspects that can be done. I know my colleagues in neurology have a hard time because you do a physical examination there is crucial to your monitoring, and that's true for other cancers. But for the cancers like I see or we heard for prostate cancer, our need to be face to face with a person or doing the physical examination is not that high.
Yeah, I think that's one of the questions that have just come in from the audience now, is around this virtual cancer treatment at home and being able to use concierge care for infusions and things like that. And Sarah, how is that done in terms of scaling up? What are some of the things that you guys have seen, from your standpoint, and how is that working in terms of scaling up a lot of home care stuff, and what's that done?
Sure. So with cancer, it's always complicated, right? So I mentioned during my introduction that this was the one ambulatory practice that we really tried to keep operations business as usual. So patients could continue their chemotherapy, continue their radiation treatments. And we also have a very active phase 1 and 2 clinical trials program that, as we've seen in cancer therapies, the early phase drugs are becoming frontline therapies faster than ever. So, where I think we've tried to shift our operations is more around less around the treatment and more around those interactions between clinician and patient in between actual treatment. We too were, scaling. We were in the middle of scaling our new telehealth solution during the early surge, and actually had to suspend the scaling of our vendor solution and turn to things like FaceTime, Teams, and Zoom in order just to, for our clinicians to be able to connect with their patients. I personally think we saw more of a, I am hopeful for the world that Dr. Fonseca laid out, where technology is going to give us more reach and access. I think what we saw, at least my personal opinion, is that we saw the technology divide increase even greater during the COVID surge in this past year, but with these glimmers of hope of how it could be different. There's a question in the chat about bandwidth or technology literacy. These are all very complex, complicated issues that, getting our providers trained up on how to do a virtual visit, never mind how to get the patient oriented to that. And so I think we still have a lot of work to do to really look at how technology can not create further disparities in care and yet create that access that I think any of us that work in digital health are working in this field because we believe that will be the case, that this will be our way of scaling and bringing our know-how to a greater population. But there's just so much more work to be done.
No doubt about it. And we've got another question coming in from the virtual auditorium. Digital health has seen an explosion recently, both in terms of venture capital and new companies. But in your experience, what are the pain points that are still persisting and that are not being addressed in oncology that can potentially be addressed by virtual care and digital health? And just going around the horn here, as it were, on my Zoom screen. Richard, you're up next. What's your opinion there? What's your thought process there?
Pain points. I think part of it is, COVID has forced people to do it, thankfully. But I think, when we talk about digital health, don't just think of a video visit or, because it can be a telephone visit. But also, when I think of digital health, it's I think of it as a really great way to we have a workforce issue that's coming, that not enough providers to manage people. And instead of thinking of I think of video visits or telephone visits as a one-to-one transfer. You're going from one in-person visit to one, video visit, but so it's still going to require the same amount of workforce. It's still going to require space to do these things. But using the digital health platform and, I think what we've been able to do is a one-to-many ratio. So, and it's been able to triage patients. So what I mean by that is that using the technology out there, and I must thank Persistent, because with Persistent and the MGB, health platform team, we were able to build a much better model than I built. And what we're seeing is, that it can triage patients to, okay, the patients that have relapsed, we know instantly because their blood work was analyzed and we can tell that there's a relapse. So they're on a higher level. Or patients with significant symptoms, we can tell that by the symptom survey they're sent. And then there's what I'll call the walking well. So then there's a whole level of patients that haven't relapsed, their labs look good, and they don't have significant symptoms. So our approach has been to what most patients want to know, and I know that I did, am I okay? So send them an instant kind of notification that, okay, you're doing well, tell them what their, scores are, tell them what the, and that they don't have any symptoms, but then give them the option to, if you'd like to schedule an in-person visit, please let us know, and we can, not in person, excuse me, a video visit or a telephone visit, we can do that. But it allows us to manage a large amount of people, because a lot of people are okay. Let me just know I'm okay. And if they want more, they can ask for it. And I think, and also looking at, we've got to think of different communication modalities and utilizing them, especially for different age groups. So a lot of my men are older. They would prefer telephone calls to video visits, or, and younger patients, it might be text messaging because, Lord knows, my daughters, that's the only way we communicate, even in the same room. So I think that, it depends on your age and it depends, but the pain points for adapting, I think part of it is making it economically viable, meaning that it's not going to hurt too much, because people can develop really great digital health things that they're not, they don't help, they cost more, or that's a big thing. But and it's also, you need to prove with metrics, that this is doing what it says, and so that was my experience, was showing a test of what we built in a smaller atmosphere, and then proving that it does this, showing them that it does this, before you'll get the attention to say, oh wait, if we scale this to the professional model, if you will, that Persistent helped us build, you can do much more and a much better thing. But it's still, you got to prove yourself.
Yeah, there's no doubt about it. And we were talking about that yesterday in another class that I teach at Columbia, and it was very much around that, around the needing of the necessity of evidence, sorry, within the model, and that's absolutely critical. And Vinood, obviously, Richard just talked about Persistent a couple of times, and what are some of your perceptions around scaling these digital solutions virtually? And how those are turning out, and more particularly back to the question of at-home concierge care. Is that feasible, and is that something that you feel that there's a great deal of future in?
Yeah, absolutely. I think Richard made a great point. I think virtual health or digital health is not just one-to-one mapping from physical visit to virtual visit where you talk to somebody on video. There is lot of scope, right, from technology standpoint, and Richard and we work together to demonstrate what technology can do. And it is not, again, goal is not to reduce number of visits. Goal is to basically to use data and really monitor this patient and the whole trajectory where this patient is going, looking at different biomarkers, looking at different clinical data, and making intelligent recommendations so that care team has the information, patient has the information, so that they make right decisions, right? I think so. This shift, in mindset, like it is just moving from physical visit to virtual visit on phone or video is just a start point in my mind, right? There are a lot of other areas where this can expand, and this is expanding into other situations and conditions. And I think oncology will greatly benefit because, as I said before, this is a long-term care situation and complex patients and high touch care delivery model, and all of this is very good scope to bring in technology and to reduce pain for the patient and bring economic element to the health system as well. So what I'm saying is, like, Stan, this is just a starting point in my mind. We're just starting on this journey, and it will take us to very nice situation, hopefully, where patient can demand for care, and before patient asks for the care, providers will be able to understand and then provide that care to the patient.
That's absolutely brilliant, Vinood. So you guys heard it here first. Vinood has created the first decision at the point of patient. It's no longer the point of care. So it's not K-pop, it's D-pop, decision at the point of patient. So that is what we're talking about, people. And Vinood, thank you. You're absolutely right. This is no longer about point of care decision making. This is now point of patient care making. Could be at their home, could be at some retreat that they're at, trying to escape the virus somewhere. And frankly, it could be at a hotel. Maybe they got trapped with COVID at a hotel and they have cancer, and they've got to get a bunch of remote telemetry stuff shipped into their hotel room so they can actually take care of themselves there. And so this DPOP model that Vinood's talking about is decision at the point of patient. Really, just absolutely spot on there. And so, Dr. Fonseca, we've got actually a question that came in specifically for you around what you're seeing. Again, you're in Arizona. For those of you who signed in late, he's not in Minnesota. He's actually one of the lucky Mayo people. So he's basking in the sun, and that's the what do you do? I mean, Arizona, I mean, we just saw in the elections, 99% of people that live in Arizona live around Phoenix, and so you've got now a good population of people that live in the middle of nowhere in the desert or in the high country on the rim above kind of in the Flagstaff, Grand Canyon area, Sedona, that are far away from your center of excellence, but not everyone has great bandwidth. And 5G is not ubiquitous. Unfortunately, for people like Qualcomm who would love it to be ubiquitous today. What do you do with people that have patients who are trying to do this stuff and they have low or no bandwidth?
Yeah, there's no question that remains one of those pain points. And as we develop this, and just being an oncologist, by definition, I have to be a pathologic optimist, right? So I want to live in that world that we're talking, where this becomes a reality for as many people as possible. I'll give you a couple of quick examples. So we realize that there's a concentration in large urban centers here in Phoenix, which is a whole other conversation, because even those that live in the west side of the city benefit from remote care, even within your own city. But when you go farther out, so many years ago, over 10 years ago, our site developed a telestroke program where we had a robotic presence at multiple ERs across the state, where one of our neurologists was on call 24/7 and would go to the bedside and do an analysis, and essentially just about making a decision whether you administer, a fibrinolytic agent or not. And that was incredibly well received in the state. But that was in the hospital. So those are the points with, with the access. Now, more recently with COVID, we saw a significant increase in the number of cases in the Navajo Nation, and that represented some challenges. So there were some opportunities in certain point areas to provide the support and provide some of the education of the healthcare providers in the communities. But the reality, it was not true for everyone. Now, my pathologic optimism comes in that there is a future that perhaps realizes, what drove, for instance, the sale of WhatsApp. WhatsApp going out for $21 billion. So, because we may not have broadband, but we have a cell phone, and if we get to the point that those solutions are more cell oriented, then it's more of a game changer. Now, so is a video essential? Perhaps not for everything. Is synchronous essential? Certainly not for everything. And I think, as Vinod was saying, this is going to evolve, and we're going to learn in new and better ways. And I wish it was a reality for everyone right now, but just being cognizant of that, and even with those limitations, there's options for more than we had in the past.
Yeah, that's spot on too. And Sarah, talk a little bit about remote monitoring. We've got a question coming in from the galley around remote monitoring being so critical in oncology. Do you think that partnering with med devices and hospitals and technology is going to be the key to the success in the future?
Absolutely. And frankly, that's a large part of my role, is to bring these complex partnerships together, because I think, as all of the other speakers here today have alluded to, there's no one magical solution, right? And so I think the trick is going to be to find a suite of solutions that you can configure together, almost like granimals, to meet the needs of that one particular patient, right? So, and historically, I think I've worked at 3 AMCs now. It's very hard for the AMCs to work with industry. We're not as nimble, we're not as quick, and so I think finding the right partnerships where the incentives are absolutely aligned, and where there's mutual understanding around what each party brings to the table. So there's incredible tech out there right now, and incredible sensors. A year from now, it'll be a whole new crop of incredible sensors that will replace today's sensors. There's a whole other bunch of platforms out there too. At the end of the day, it's got to be, what's the right fit and what's the right environment to really innovate. And so I think when we look at our industry partners and who we're going to innovate with, we don't look for one. I may pick a platform, a different sensor, a different coaching protocol, and try to bring these things together to really meet the needs of the patient. So I think it's not just one partnership, it's actually going to be multi-partner partnerships towards innovation. And in that case, it's really around finding who's the right fit culturally for the partnership itself to make the quickest and most impactful solution to bring that to market.
And what are some of the better ones that you've seen now? What are some of the sensors? And that kind of goes into another question I'd like to talk a little bit about, is what are some of the better digital health technologies that you've seen help cancer patients today, that help empower telemedicine, remote monitoring, and you know, EHRs and other things?
Yeah, so certainly I can't, because of our, you know, conflict of interest policies, I can't give a particular brand or company, but I will give the, I'm happy to share some of the success factors I guess I've seen or criteria. How about that?
How about a generic platform?
Generic platform, great. So platforms that incorporate a patient's personal health record and personal health data, and that can aggregate that data with new data types we don't traditionally collect in the clinical setting. So EPROs, physiological monitoring data, even from consumer wearables, it's more information than we have now. Configuring those platforms and the EPROs to really elicit information from the patient, preferably prior to a visit or phone call, so that the clinician knows what they're walking into and potentially can have a treatment plan ready ahead of time. You know, with the sensors, I think we overcomplicate the sensors, frankly. You know, and in the certainly at a place like Mass General, where we're seeing some of the sickest and most seriously ill patients, you know, we tend to go towards, we need that FDA approved full-on medical device. Well, do you really need that in the home hospital, or can I get a $20 SpO2 on Amazon and ship it to my mom and we're going to be okay, right? So I think really looking at the environment of where the patient is and then identifying, but there's plenty of good solutions out there, including consumer wearables like Fitbit, Watch by Apple, that can give you just some really key data points that that you need, like just activity, accelerometry, falls. There's all sorts of stuff out there now. It's really then about integrating that into the right platform. I think that brings this other data that we don't easily have access to from the patient, that is starting to show game-changing effects.
Completely agreed. And Richard, some of the platforms, if you can't talk specific
yeah, I probably should follow
tools.
Sarah's lead and not say specific platforms, because I'm sure I would get reprimanded. But no, I think for me, I see CRM software, the customer management stuff that a lot of the that businesses have been using for years, fits really well for what my needs and what I would, because I'm able to create a multi-communication modalities outreach to patients. Plus, you build in clinical data analytics that you can extract from the EMR with whatever you need, and you're also getting ultimately, I envision this like Persistent has talked about, is empowering the patients, because if you're building in communication ability, the analytics to whether the patient's doing well or not, and it's spitting out, it's not only helping the clinician, but it could actually communicate that back to the patient, and patients are empowered and can self-manage them. But I think but it is, like Sarah said, it's a combination of, like, the CRM software seems to be built. Again, I'm very naive to all the other stuff, but it's built that you can have it doing so many different things, and that is the key. Like Sarah said, is you don't want to fall victim to just one approach. You need to look at how do you address that, and as we've talked about, how do you address an underserved community that might not have the bandwidth, but using cell phones and things like that, but building one platform that can outreach in multiple ways, whether it be emails or whether it be text messaging, but using the same kind of messaging and things like that. I mean, I think we've only scratched the surface with that.
Absolutely agreed. I think there's a lot more to learn about this. We are really at the very beginning of a very complex and long journey. And certainly one of the things that everyone wants to hear about, and again, anyone in the audience who has a question, please just pop it up on the chat bar or the Q&A box. But something that we've certainly discussed in the past is around value-based care, right, Dr. Fonseca, and how these digital tools are going to either really prove themselves out in a value-based care model or fail and it really end up washing out. And so What's your perspective there, and how do you see these tools enabling the value-based care model, or do you see some of these tools going away because they just don't have a role in value-based care?
No. I think they will, and the next generation of health economists have a whole new field in which they're going to be working as they try to integrate the considerations that come from this. So in systems, in closed systems and capitated systems, I think that they're going to track this perhaps even more carefully than in the traditional fee-for-service model. And but the reality is that a lot of this will open possibilities for larger contracts as well too. And particularly as one thinks about the rare disorders, that can think of multiple examples of things that we all do and we are supposed to cover. So for instance, I'm a hematologist, and so when I'm doing the consult service, I'm supposed to cover TTP in the hospital. But there are 5 national experts on TTP. So if you're a health plan, won't you have a lot of benefit from having someone chime in and come and help in your system and get the right treatment, some of which are particularly expensive for the right patients, and do the right testing. And that conversation you can extend to so many other aspects. To me, the key aspect of value is doing the right thing for the right patient, and particularly as that involves some of the newer technologies with the significant implications to expenses to the system. So again, I just think that the conversation has just started for the health economists of the future.
Agreed. Absolutely agreed there for sure. And I think that's one of the things that people are struggling with right now. Is that how do we actually prove the economic efficacy through the clinical testing, the experiential testing, because it's so broad and it's so difficult to show that a digital health tool is working over every audience all the time. It really doesn't. Digital technologies work very differently for different therapeutic populations, different demographics, et cetera. So it's really important. We've got a couple of questions that are coming in from the audience now. Is there a way for other members of healthcare continuum, whether it's pharmacies or pharmaceutical companies, to get involved with virtual care, specifically cancer care? In other words, any way that they can support hospitals, physicians, and patients using the therapies? How are some of these other stakeholders that are not directly related to the provision and delivery of healthcare, that aren't touching patients necessarily, what can they do to help you guys out? And again, we're going around the horn here. Go back to Sarah. Sarah, what you're sitting in one of the biggest hospitals in the country. What do you guys, how, and it's kind of going back to that partner question, the question on partnering. What do you guys see as the non-patient-based stakeholders being able to do to help you out?
So I have to say, I think this is going to be the decade of pharma. For pharma to show its, at least for the AMCs, we've had some of our most successful digital health partnerships working with pharmacos. And I think this probably can touch upon Rama's question too. And I hope I'm saying your name correctly, Rama, in that, where pharma and the AMCs are so well aligned is around the need for rigor and scientific proof in order to bring something to market, or in our case, administer it to a patient. So I think that our incentives and our constraints are actually very much aligned. And so that has really helped fuel some very successful partnerships, especially as it relates to enrolling and patients in clinical trials, and more importantly, keeping those patients engaged in the trial. Now, I would say that I think in the cancer world, it's different. You have a much more motivated patient population, which is great for innovation, but doesn't necessarily account for that last mile that you're going to see with other patient populations where there's less motivation. So I think there's still some work to be done there, where we have a couple of partnerships in progress now around with pharma partners, or more around taking care of patients with chronic diseases like heart failure, diabetes, hyperkalemia. And I think what we're seeing is that there's first of all, any technology that enables the patient to connect with a clinician or provider is key, whether it be through chat but also gamification. And that, maybe it's because we're all bored right now and we're stuck at home, and, it's more fun to play 2-dot than it is to be on Zoom. But anything in the gamification space, and seen a lot of success for that, especially in the cancer world. So, and we tend to roll out any of our digital health technologies that we either co-create or are piloting in the research space, because we want to see how it does in terms of helping with enrollment and adherence to clinical trials in particular.
Yeah, that's wonderful. I know Vinod, you've been really active in helping build a lot of those partnerships, across stakeholders like pharma and hospitals. Maybe you can shed some more light on how that goes and how that works.
Yeah, absolutely. So we are seeing, COVID was like one step, where there was a bigger push for digital health, and I think post COVID, because now everybody's kind of trying to innovate, right? And they have been forced to innovate. So what we are observing is, there are very different type of partnerships and models, care models are going to emerge, with tools in hand, and then there is another factor that is playing out from previous question is value for care. So all these parameters are going to drive these healthcare ecosystem companies like providers, pharmaco, researchers to come together to to provide better testing, a diagnosis, better diagnosis, faster diagnosis, accurate diagnosis, right? And then also care delivery. So I think this whole engine is going to be kind of pushed with more thrust, right? And COVID is being that thrust, fortunately, unfortunately. But this what Sarah said is like, is very interesting, that how all these different kind of partnerships are going to emerge, and pharmaco companies are, definitely are going to be part of that. And we are very thrilled to partner with some of these early ventures and being technology partner to some of these healthcare ecosystem players as well.
Yeah, I think that's absolutely right. Now, there's another question from Pankaj, and Richard, he's wondering what role can a pharmacist play in the virtualization of cancer care, and how are you seeing pharmacies and pharmacists help out with the primary care effort? And and we've got about 3 minutes left, just to be respectful for everyone's evening here, top of the hour. But what have you seen in Boston?
Well,
and
a quick shot. I mean, I've seen where the digital health, where they're building a platform that basically, the same way I talked about connecting with patients. Well, if you've got an outside pharmacy or an infusion company or things like that, you're building a health platform that can communicate from we'll say the Brigham to the to the pharmacy, or that's getting it out immediately, or that's translating the information that they need, and building a platform that can get the information to them in the form they need it, based on what the provider is prescribing, or what that I think it's really being able to communicate faster, quicker, and and it actually, I think what it really is going to do is help to standardize what goes out, and what goes out to the pharmacies, what goes out to all these companies, and it's connecting them. And or even, like, we'll say, private social workers that you could send referrals immediately, those type of things, where if there's a need, you'll build the connection to fill it.
Yep.
That makes any sense at all.
That makes a ton of sense. I think that's, again, that goes to the critical role that pharmacists have played. And I think we've seen that along the entire continuum, just the roles that people are playing to step up during this time of need. And it's been absolutely critical. Well, Doug, this has been absolutely phenomenal. Again, I can't thank the honored panelists enough for what they've been able to go through today. I think we've learned a lot around what is going on, how cancer care is being revolutionized during the pandemic. And if there is a silver lining on this, it's that we're getting much smarter about how to deliver remote care, and hopefully that'll improve the diffusion of cancer care all over the world, so that people that are in small communities far away from subspecialists are able to access those subspecialists in ways they've never been able to do before. Again, thank you everybody for a terrific panel. Thank you, Persistent, for your tremendous support of these webinars on the Virtualization of Care series. And for all the people in the audience, thank you for your tremendous engagement. And please have a great weekend and stay safe. Good night, everybody.
Thank you.
Thank you.
Thank you all.